Assalamu alaikum. So today's topic is diabetes insipidus, which is characterized by the production of large amount of diluted urine. D for diabetes insipidus and D for diluted urine. It could be with or without thirst. Urine specific gravity is low and urine osmolality is also low. There are basically four types. This is central diabetes insipidus, nephrogenic diabetes insipidus, and there is also gestational diabetes insipidus. And these conditions can be differentiated from primary polydipsia, which is basically an excessive water intake, which occurs in psychiatric illnesses or when there is an hypothalamic lesions that affect the thirst centers. So now central diabetes insipidus and nephrogenic diabetes insipidus. In central diabetes insipidus, there is decreased ADH release. That could be idiopathic or that can be due to any brain injury that can be caused by trauma, hypoxia, tumor, surgery or infiltrated diseases. Whereas nephrogenic diabetes insipidus is when there is ADH resistance. It could be hereditary when there is mutation in the ADH receptors. It could be due to drugs, for example, lithium, democlocycline, or it could be due to the metabolic disorders such as hypercalcemia and hypokalemia. In both central diabetes insipidus and nephrogenic diabetes insipidus, the serum osmolality is increased, whereas in polydipsia, the serum osmolality is less or it is decreased. ADH level is decreased in central diabetes insipidus since there is a lesion in the hypothalamus that decrease the secretion of ADH, whereas in nephrogenic diabetes insipidus the ADH is normal or it is increased. There is only the resistance for the resistance ADH resistance, right? And in primary polydipsia, ADH level can be decreased or it could be normal. So the management is polydipsia. Primary polydipsia is water restriction. That is a behavioral therapy. Whereas in central diabetes insipidus, we will give the external ADH, that is desmopressin. And in nephrogenic diabetes insipidus, that can be managed by managing the underlying cause. For example, you can use low solute diet or thiazide diuretics or amiloride or indomethacin. In gestational diabetes insipidus, vasopressinase enzyme is released in 8th week of gestation and it peak at third trimester. It breaks down the ADH, so there is decreased ADH in the blood. So there is going to be excessive production of diluted urine, and it may last 2 months postpartum, and then it becomes normal. The test for diagnosis of diabetes insipidus is the water restriction test and the desmopressin administration. In water restriction test, there is no water intake for 2 to 3 hours, followed by hourly measurement of urine volume and osmolality, as well as plasma sodium concentration and osmolality. If there is a significant increase in urine osmolality after the water restriction, then that is primary polydipsia. If there is no change or slight increase in urine osmolality, then that is the diabetes insipidus, either central or nephrogenic. So to differentiate between central and nephrogenic diabetes insipidus, then we are going to do desmopressin ADH analog test. It is administered if serum osmolality is less than 295 to 300 milliosmol and plasma sodium concentration is more than 145, or urine osmolality does not increase despite the increase in plasma osmolality. So if there is minimal change in urine osmolality, then that is nephrogenic diabetes insipidus, and if there is significant increase in urine osmolality, then that is the central diabetes insipidus. So this was all about primary polydipsia and diabetes insipidus. Thank you for listening.